with Gleneagles Hospital. Our speaker today is Dr. Thaneshkumar. He is our consultant hepatobiliary surgeon in Hospital Queen Elizabeth Hospital. A bit about our HPB surgeon. He graduated from the USM in 2006, and he's got his Masters of Surgery from UM in year 2015. He's got his FRCS in 2017, and he is now the head of unit of HPB in Queen Elizabeth Hospital. He is also our vice president of the Sabah Surgical Society. Without further delay, I would like to invite Dr. Thaneshkumar for his talk on pancreatic cancer. Catch me early if you can. Dr. Thanesh.
Well, thank you, Dr. Pepe, for your very kind introduction. Good evening, everyone, and thank you for joining us today. My name is Thaneshkumar, and I'm currently practicing in Hospital Queen Elizabeth Sabah as the general and HPB surgeon. The title of my talk today is going to be about pancreatic cancer. Catch me early if you can. This is the outline of my presentation. This is probably a very brief overview of how do we manage pancreatic cancers and the basics that we need to know. First, I'm going to talk about a little bit about the epidemiology, anatomy and function of the pancreas, the tumor histology and symptoms based on the location of the tumor on the pancreas, the workup and staging, management and outcome, and how can we help our patients. Well, pancreatic cancer is predicted to become the second leading cause of cancer death by year 2030. Thus, about 5,000 men and women will be diagnosed of pancreatic cancer, and this data is from Australia, and about 3 to 3.5 thousand men and women will die from pancreatic cancer in year 2021. The chances of surviving pancreatic cancer will be 11.5% in 5 years. So as we look at the survival rates of upper gastrointestinal and hepatobiliary cancers, we can see the pancreatic cancer, the 5-year survival is about 11.5%. What initially started of less than 5% over the years due to advancement in medicine and current practice, currently it has reached to the level of 11%. So this is a bit of our local data. Berdasarkan pada Malaysian National Cancer Registry report from 2012 to 2016, the incidence of pancreatic cancer is about 3% from the reported cancer. This is a very rare tumor actually. And when we look at the WHO Global Can 2020, there's estimated about 1,100 pancreatic cancers reported in Malaysia in the year 2020. Sadly to say, 70 to 80% of those patients, they always present with unresectable or metastatic disease upon presentation. So this is why it's very important for us to catch pancreatic cancer early so that we can treat till we can cure them. So talking a bit about the anatomy of function of pancreas. As we can see, the pancreas is situated in the retroperitoneal region with a close proximity to the stomach and the colon. And also a major blood vessel like the aorta, IVC, superior mesenteric artery, superior mesenteric vein, and also the celiac axis. It can be divided into 4 regions actually: the head and the uncinate process, the pancreatic neck, the body of the pancreas, the tail, which is in close proximity to the spleen. As for the function of pancreas, it is known to have an exocrine and endocrine function. The exocrine function is mainly for digestion, while the endocrine function is mainly for the homeostasis of our sugar control. Talking about the common histology of pancreatic cancer is usually the pancreatical ductal adenocarcinoma. It makes up to 90 to 95%. The rest of the histology is quite rare, and one of the other regular ones that we get, one of the rare ones that we do get once in a while will be the pancreatic neuroendocrine tumor or pancreatic endocrine tumor or islet cell tumor. Looking at the location on the pancreas, the most common site of getting a pancreatic cancer will be at the head. This is roughly about 70 to 80%, whereas the remainder 10% will be at the body, and another 10% will be at the tail. So the symptoms of pancreatic cancer usually depends on the location where it arises from the pancreas. As we can see, the most common symptom reported is mainly weight loss, and jaundice is quite common when it's located at the head of pancreas. Besides that, we can see the symptoms are pretty much very vague and non-specific, like pain, anorexia, nausea, vomiting and weakness. So this is the particular reason why that patients who develop pancreatic cancer does not exhibit any symptoms at a very early stage. So high index of suspicion is actually needed to detect this cancer early. As we move on to the workup, how do you work up pancreatic adenocarcinomas? The most important thing is the history. First, we need to identify their risk factors. Are they at risk of developing pancreatic cancers? The signs and symptoms. At the same time, a quick assessment on the fitness of surgery. Like I mentioned before, the sign and symptoms is not very specific for pancreatic cancer. Sometimes it can be very vague: recurrent epigastric pain, loss of weight, loss of appetite. So we need to have a high index of suspicion. In terms of physical examination, there are few signs and symptoms that are suggestive of advanced disease, mainly ascites, probably mass per abdomen, and also lung symptoms, respiratory symptoms. We also need to assess the nutrition of this patient to see the mode of treatment that we're going to embark on. Subsequently, investigating patients who have suspect of having pancreatic cancers. So we can be divided into biochemical, which I will go in detail later, imaging, staging, and also whether these tumors are resectable. In terms of management, it will be divided into curative or palliative intent. Talking about the risk factors, it's quite common for most types of cancers that we get. So number one is family history. Of course, if there's any history among multiple first degree relatives and those who are diagnosed less than 50 years old, then that particular individual is at risk. In terms of diet, a diet high in red and processed meats increase the risk of getting pancreatic malignancy, whereas a diet high in fruits and vegetable may decrease the risk. Obesity. Obese people have 20% increased risk of developing the disease compared to people of normal weight. Smoking may cause about 20 to 30% of all exocrine pancreatic cancers. The gender, slightly more male inclined compared to the female. Advancing age, the chance of developing pancreatic cancer increases with age. Diabetes, long-standing, increases the risk. In fact, new onset of diabetes may be the only symptom of developing pancreatic cancer. Chronic pancreatitis, those who has chronic pancreatitis due to alcohol or any other reason increases the risk of developing pancreatic cancer. Well, moving on to history and examination. This is a repetition of the previous slide. Like I mentioned earlier, the symptoms may not be very specific for pancreatic cancers. So patients may remain asymptomatic or have non-specific symptoms at early stages of illness. Talking about advanced disease, where patients present with ascites, respiratory symptoms, cachexia, mass per abdomen, or they may have lymph nodes, mainly at the upper cervical region. Moving on to the investigation. First and foremost, we most likely will be, after taking a full history and examination, we'll probably be doing some blood investigation. So routine blood investigation, that full blood count, renal profile, liver function test, and coagulation profile. Talking about liver function test, those with jaundice will have an elevated serum bilirubin level and alkaline phosphatase, suggestive of obstruction. And talking about tumor markers, CA99, the normal level is less than 37 units per mil. A level more than 100 is suggestive, and anything more than 1000 is strongly associated with an advanced or unresectable disease. Having said that, CA99 has its limitations. It can be elevated in benign obstructive jaundice patients, like those who are having choledocholitis, stone in the CBD, and also negative LEVI A and B antigen patients, and that makes up to 1/3 of the population. Besides that, we will also like to do chest X-ray and ECG. So this is mainly to assess the patient's fitness for surgery, and chest X-ray if we can, if there's any evidence of advanced metastatic disease to the lung. Moving on, the other modalities of imaging. So talking about ultrasound, ultrasound is only sensitive to 70 to 80%, and we may get like dilated biliary tree in terms of obstructive jaundice, or we can even see a mass. But most of the time this is operator dependent and can be technically difficult and may miss smaller tumors. The current standards of investigating pancreatic cancer is CT pancreatic protocol, and it is sensitive up to 90 to 95%, and is also important as it gives us a picture whether the tumor is resectable or not. Talking about MRI, it's not really superior to CT, but usually used in selected patients where we like to see the extension of the plane beyond the pancreas, and also in cystic tumors, and also its relation to the pancreatic duct. Moving on to EUS, endoscopic ultrasound is superior to CT in picking up very small lesions, and it also has a benefit of acquiring tissue diagnosis, and is much superior in detecting venous invasion compared to CT. ERCP is not endoscopic retrograde cholangiopancreaticogram, is not used for diagnostic purposes, and it has a 5% complication rate, and it's mostly used in patients who have obstructive jaundice, where we want to bring down the jaundice and to optimize them for surgery. PET scan, if there's any doubt about metastatic disease and not routinely used. Diagnostic laparoscopy or staging laparoscopy, there's a 20% chance where peritoneal mets can be missed by CT. So hence the diagnostic laparoscopy or staging laparoscopy will be beneficial. So most of the time we don't need to embark on all the investigation. A CT itself may be adequate for us to decide further. And talking about staging, so we use the NCCN guidelines and the TNM staging. So I'd like to bring your attention to these T4 tumors. As we can see from T1 to T2 to T3, mainly we talk about the dimension of the tumor. So any tumor more than 4 centimeters is considered to be T3. But when we look at T4 tumors, these are tumors that involve the celiac axis, superior mesenteric artery, common hepatic artery, regardless of the size. And if we look at the staging, we look at stage 3 onwards, where T4 tumors is considered stage 3, and stage 4 when there's presence of M1 disease. The reason why I say so is because, why this is important is because when you have a T4 tumor and there's a vascular encasement, so most of the time this becomes unresectable. So to pick up the tumor within T1, T2 and T3 stage, that's where we need to be a bit vigilant in terms of history and clinical examination. Talking about resectability, so we can divide the tumors into whether it's resectable, borderline resectable, or locally advanced. Resectable tumors are those who doesn't have any contact with the arteries or a reconstructable portal vein contact, whereas those who have locally advanced tumors are those who has a solid tumor contact of more than 180 degrees of the SME or celiac axis, and unreconstructable SMV portal vein due to tumor involvement or occlusion. Anything in between comes under the borderline resectable case. Moving on to the management. So how do we manage pancreatic cancers? So like all tumors, it's a multidisciplinary approach. It involves the surgeon, hepatobiliary surgeon, the gastro specialist, gastroenterologist, radiologist, oncologist, pathologist, and in fact may involve the palliative care physicians and the nutritionists and also physiotherapists. So the aim of this management surgery will be ability to achieve a RO resection to get a clear resection margin, and subsequently we need to decide whether the intent is palliative or curative. Talking about surgery, so surgery is an option for cure. So and the type of surgery depends on anatomical location of the tumor. So when we get a tumor at the head and neck region, so the type of surgery with pylorus preserving pancreaticoduodenectomy, or what we call as PPPD, or the classical pancreatic duodenectomy, which is a Whipple's procedure. When we get the tumor at the body or tail, so we do a distal pancreatectomy and splenectomy, which we call as radical antegrade modular pancreaticosplenectomy. And in rare circumstances, we may need to embark on total pancreatectomy. So we talk about the survival of the patient as stage dependent. So as we can see, resected patients, the survival are much better compared to non-resected patients. Well, this is a operative field after we have removed the tumor. As we can see here, this is a specimen, and this is where the area highlighted with this green is where we can see the tumor, and this is actually the transection point is at the neck, far away from the tumor. And we do also remove the gallbladder and also part of the small bowel, and we anastomose back to re-establish the route for the biliary, pancreatic, and also the gastric content. So as we can see in this image, we can see how close was this tumor to the major vessels like the IVC, left renal vein, the aorta. This is the portal vein assembly complex, and this is the right hepatic artery, which happened to cross early behind the portal vein, and this is the distal pancreatic stump, which we will use further for anastomosis. So we need also do a proper resection plus a lymph node clearance to prevent early recurrence. So as we can see in this image here, once we remove the tumor, we will re-anastomose back the pancreas, the bile duct, and also the duodenum or the stomach. So when we talk about PPPD or Whipple, it's actually a complex procedure. It carries a mortality of 5% and morbidity of 20%. It usually takes 5 to 8 hours. There's a risk of anastomotic leak or post-operative pancreatic fistula, and sepsis in terms of superficial or deep surgical site infection, lungs, and also the abdomen. It also carries a risk of bleeding, and post-operatively there can be impaired glycemic control and also nutritional issues like steatorrhea, where I need to be treated with crayon or pancreatic enzyme supplements. Having said that, as we can see, the 5 years survival for cancer by comparison, we talk about breast, prostate, and colon, is somewhere around 90%, and colon is about 60%, and lung is about 50+%. When we talk about pancreatic cancer, what it started off with less than 5%, over the years has improved to 11% thanks to multimodal therapies and multidisciplinary team interventions. So surgery is a potential cure for pancreatic cancer, and a watchful waiting is pretty much never an appropriate option. The management strategy is therefore primarily dictated whether tumor is resectable or not, and other important factors which includes the patient's overall health and their fitness for major surgery and post-operative chemotherapy. There are treatments available to both cure resectable cancers and to palliate unresectable disease to improve the quality of life, and these are supported by the use of adjuvant medical therapies such as chemoradiotherapy and pain control measures. Recent times there's actually emerging evidences on usage of pre-operative chemotherapy to improve the R0 resection rate, and the decision to whether to embark on pre-operative chemotherapy or to continue with the post-operative chemotherapy, it depends on a discussion and multidisciplinary team discussion, and is very patient specific. In terms of oncological management, so it can be divided into adjuvant setting, neoadjuvant, or palliative setting. So there's various studies have done, there's various regimes of chemotherapy had been tried over the years, and at the current moment is usually be gemcitabine based. When we talk about neoadjuvant chemotherapy, this is like giving a chemo upfront before the surgery. So it's given in borderline resectable cases where vessels are involved, hence we may not be able to achieve an R0 resection rate. So studies have shown by administering neoadjuvant chemotherapy, it improves the resection rate up to 74% with a median survival at 34 months. So advantage of pre-operative neoadjuvant versus the standard post-operative adjuvant setting offers several potential advantages. Number one, it eliminates the risk of delayed or incomplete treatment post-operatively. As when we do a surgery, patient needs time to recover. So even though they can be back home within 5 to 7 days, for them to come back to a proper functional status, it may take a month with the wound healing, and so so this might delay the chemotherapy. So that's why if we are given pre-operatively and we done the surgery, so it may eliminate the risk of delayed or incomplete treatment. Patients who manifest metastatic disease during the course of neoadjuvant therapy will not benefit from a curative resection. Thus, they will avoid an operation which is unlikely to be beneficial or any survival benefit. That in terms of palliative, right? So what can we offer? So when there's an unresectable tumor, so there's an option of palliative chemotherapy. This does not cure, but there is an evidence for survival benefit in terms of palliative chemotherapy. And when patient presents with jaundice, there's always an option of biliary decompression and stenting. ERCP or PTBD with stenting is a preferred route compared to bypass surgery. When patient has a duodenal obstruction because of close proximity of the pancreatic cancer to the duodenum, so there's an option of duodenal stenting versus surgery. Talking about pain relief, there's various choices of analgesia. Usually will involve the APS team or the acute pain service team in our hospital, and the pain physician will be involved in administrating different types of analgesia suiting the patient. And the other option will be a CPN or celiac plexus neurolysis. So this can be neurolysis. This can be done using the endoscopic method or interventional radiology. Subsequent management of ascites, pleural effusion, and also nutritional management. Patients may also need psychological and probably emotional support. What's the aim of this is to improve the quality of life. So this is going to be my last slide. So what can actually we do to, so the most important is to catch the pancreatic cancer early at a point is still resectable. So as we know, the signs and symptoms are not specific, so we play an important role on detecting the cancer early. So how do we do it? So based on history, family history, and then we need to risk stratify, and we also have to have a very high index of suspicion. Patients presenting with unexplained loss of appetite or weight, recurrent epigastric pain needs further investigation. Although pancreatic cancer is rare, but we still need to investigate further with endoscopy. They may have other kinds of upper GI malignancies like gastric cancer, and the only way to know whether patient has a pancreatic cancer is via our CT scan. So my advice is, if we suspect that one of our patients have pancreatic cancer, is to refer early to a specialized centers for further workup. Well, that will be the end of my talk today. Thank you very much.
Thank you very much, Dr. Thanesh, for his enlightening talk. If you've got any questions that you want to ask, please send it in the comment section below, and we'll try our best to answer it. We'll take a 5 minutes break, and we'll be back with the questions and answers, okay? I'm just going to read it out. From Nakiran, he would like to know about the role of PET scan if we need to do PET scan for all patients with pancreatic cancer. Thank you.
Well, thank you for the question. So, PET scan is not routinely used for pancreatic cancer. So, usually we'll start with a staging CT with pancreatic protocol. Hence, then we will decide whether this patient has a resectable disease or any evidence of metastasis. If there's any doubt of metastasis, then PET scan will be a good option. And also in the event of post-surgery and patients on chemotherapy and there's any evidence of recurrence, suspicious recurrence on the surveillance CT, then we might use a PET scan to see if there's any evidence of metastasis. The other thing is when we monitor CA99 post-operatively, and if it's going up and none of the imaging actually picks up any lesion, so in that circumstances we can also use a PET scan.
Okay, thank you very much. We've got another question. Can we use CA99 as a diagnostic tool for pancreatic cancer?
Well, unlike other tumor markers like PSA or CEA, PSA, CA99 is probably about 80% sensitive and specific for pancreatic cancers. But the problem with CA99 is also elevated in patients who are jaundiced. So this jaundice can be because of benign conditions like choledocholithiasis, right? So it may not be a very sensitive marker to use or to diagnose pancreatic cancer, but elevated CA99 do warrant an investigation, a further investigation with high quality CT scan and MRI or EUS.
Okay. The next question is somewhat related. How, for patients with incidental finding of raised CA99, how to investigate and how far would you investigate?
Well, when the patient has a raised CA99, the best thing to see is still after a full history clinical examination is to order for a CT, a pancreatic protocol, well, to see if there's any lesions in the pancreas. So if we are suspecting a pancreatic cancer based on the pre-operative, initial workup, yeah. So only a CT scan can actually, an imaging can actually tell you whether there's any lesion in the pancreas or not. None of the other tumor markers or by history or by clinical examination we can conclude that patient has something. So a CT, we start off with a CT first, then probably from there on then we see whether there's a need of other things like MRI or EUS.
Okay, thank you very much. Is there anyone with any more questions? You can leave it in the comment section below. Okay, one last question for Dr. Thanesh. Since pancreatic cancer is quite difficult to pick up and the symptoms are quite vague and non-suggestive, is there any screening program or anything to do to screen for this pancreatic cancer?
At this point of time, like we don't have any screening programs for pancreatic cancers, unlike breast or in some centers colorectal. We don't have for pancreatic cancers. Probably is because of the rarity of the illness, number one, and so it's based on how the physicians or clinicians, when they get a patient, and it's based on their initial suspicion whether this patient could have a pancreatic cancer. So to answer that question, there's no screening program advocated for pancreatic cancers. So I would advise people to probably lead a healthy lifestyle to reduce the risk of developing pancreatic cancers, and also to see your physicians or clinicians early to for any symptoms that occur pertaining to pancreatic cancer.
Okay, any more questions from the public? If there are no further questions, I think we will end our session today. Thank you very much, Dr. Thaneshkumar, and thank you all for joining us today.
Well, thank you very much for giving me this opportunity to talk. Thank you to Sabah Surgical Society and Gleneagles. Please stay tuned for the next Surge Talk. Will be on this Saturday with Mr. Krishnan, or Mr. Dr. Krishnan from colorectal surgery. Thank you. Thank you, Pepe.
Okay.